Okay, Dr. Silber, your next question is, what tests do you recommend?
Well, I think that you can do this very simply, or you can overdo it and spend a fortune. Better to do it very simply. So, obviously, for the male, the sperm count is still important. It includes the motility of the sperm and the structure of the sperm, called morphology, and the number of sperm. That is really, I mean, there are a lot of modern attempts at tests like DNA sperm fragmentation and the old hamster test. I mean, there are so many different kinds of testing that are worthless and they just cost a lot more money. So you need the sperm count. Now, if we're going to do IVF, we don't care what the sperm count is as long as there's any sperm at all, because we pick the sperm up by the tail and inject it directly into the egg. And you don't need 100 million or 50 million or 10 million or 10,000 or 100 or even 20 sperm. All you need is a few sperm. It's amazing. And we first did that in 1992. And so our experience is enormous with it. And we just don't care what the sperm count is as long as there's any sperm whatsoever. And even if there's no sperm, we can always do a micro procedure on the testes, and 60% of the time find a few sperm there, which are all we need, again, for this technique of injecting the sperm into the egg, which we call ICSI. Now, as far as the female is concerned, the most important thing is her age. That is the one most important indication of the fertility of her eggs, is just her age. And then, of course, you want to do an AMH and an ultrasound so you have an idea how many eggs she has. That's important to some degree, because the major cause of infertility, this huge increase, is that as the ovary gets older, the number of eggs goes down and the baby rate per egg goes down. And so the most important thing for the woman is to find out what her ovarian reserve is with either an antral follicle count on ultrasound or an AMH level, or both. The next thing that's really important is just her menstrual history. If you're really a smart clinician, you can make a diagnosis on menstrual history. If she has totally irregular cycles that can vary from 20 days to 45 days apart or twice a year, well, you know that she's got PCOS. In other words, so many eggs that they inhibit the pituitary gland, she never ovulates and never recruits a dominant follicle. And you know whether that's the case just by the history, actually, is all you need. So I'm making this very simplistic because you could spend $10,000 to $20,000 on tests that aren't really necessary. And so ultrasound usually will tell you what you need to know about the structure of the uterus and the fallopian tubes, vagina. However, sometimes you need to do what we call a hysterocell pentagram to see whether the tubes are either blocked or whether they're dilated. And so the hysterocell pentagram is about $1,000 and it's painful. So if we can get around that just with a three-dimensional high-definition ultrasound, then we'd rather do that than put you through the hysterocell pentagram. But sometimes you need the hysterocell pentagram. So I've mentioned it. I mean, there was, when we were in Paris just in May, and I delivered my talk about ovary transplantation, which I mentioned earlier, there was one fantastic talk by a European showing that with ultrasound and just injecting fluid, but fluid with bubbles in it, you can see not just the uterus, but you can actually see the fallopian tubes very clearly. So, and you can do an antral follicle count to know the ovarian reserve. So this doctor was making the point that you can get by with just one test on the woman to know what you need to know before treatment or recommendations. So I'd keep it simple and not waste a lot of money on too much testing.